Hello and welcome everyone to the Key Populations Oral Abstract Sessions, African, Caribbean and Black People. Bonjour à tous et à toutes. Bienvenue dans la séance de présentation orale d'Aberger sur les populations clés africains, caraïbéens et noirs. It is my pleasure to introduce the first presenter today, Charmaine Williams, who is a professor at the Factor Inwintush Faculty of Social Work at the University of Toronto. Welcome, Charmaine. You can go ahead.
Thank you. I'm just going to put up my screen. And I can't tell if that's right. Can somebody tell me if that looks? No, it's not right. That's right.
Yeah, okay. Looks good now.
Oh, thank you. Thank you. Right, good afternoon and good morning, good evening, everyone. Really pleased to be here. My name is Charmaine Williams. I'm a professor at the University of Toronto in Toronto, which is Treaty 13 territory. And you see the names of my collaborators on this first slide, the collaborators on this paper, but I will talk a bit more about the size of the project as well. So very glad to be here in this session and looking forward to all of the talks. So this is a paper about resilience and HIV prevention for heterosexual Black men in Toronto, Canada. And I kind of wanted to start off first by just talking a bit about the idea of resilience, because resilience is something that we hear about a lot. And lately I'm beginning to wonder if the term is still useful for me or palatable for me. I think that the signal for me was when my university announced that they had a university resilience committee constructed. And I kind of thought, well, now I just feel like this word isn't useful anymore, because resilience used to be this word that we talk about in terms of how people in marginalized circumstances are able to survive and withstand those marginalized circumstances. And by the time you start applying it to places like this enormous university, it starts to feel like it's been co-opted or something. I mean, the other side of that is that resilience is something that often gets sort of plucked out of the findings of studies when they are describing terrible circumstances and terrible things. And then they sort of say, oh, but we found that there was resilience. And this is why these people are still here, still surviving, still thriving, still doing what they need to do because of resilience. And so it's like this emergent explanation that kind of seems to let people, let the rest of us off the hook, right? Because we can congratulate whoever this marginalized group of people is on their resilience, and that means that everything's fine. But I am going to say that, like I said, this is a paper about resilience in the context of HIV prevention for heterosexual Black men. And I'm going to insist on its usefulness, at least for the length of this presentation, because I think something that was important about the way we approached it in this study was that we weren't waiting to discover resilience as if it was this thing underneath all of the troubles. Instead, we started from a position that resilience was there. We knew it was there, and that it was something we needed to understand better in order to think about the issues that were at the focus of this work. So I'll be talking about how we took that up in the study, and then how I think it is still useful in the context of HIV prevention for Black men. So part of the context here is that heterosexual Black men in Canada are part of communities that are at disproportionate risk for HIV. And I'm going to imagine that there have probably been several presentations that might have addressed the reasons for this. Certainly it is a health disparity like other health disparities that affect Black communities in Canada, and it cannot be separated from issues of structural violence and social determinants of health and anti-Black racism that underlies both and affects all of the institutions that we interact with as members of Black communities, with effects on things like education and health and employment and all these things that affect our health. So here we are, a population that's disproportionately affected by HIV, and certainly with the HIV in Black communities, we knew that a lot of the transmission was through heterosexual relationships. So heterosexual Black men were certainly implicated in our understanding of what posed HIV risk and contributed to HIV prevalence. But in terms of the early work on this, and especially the public health interventions, heterosexual Black men were really not a priority, overlooked, marginalized, sometimes blamed, and really not seen as a group to focus attention on in the same way we might have with other groups. And so the We Speak study was part of a program of research by others that was focusing on heterosexual Black men. And this particular arm of it was had these goals of raising awareness around HIV with heterosexual Black men, doing the type of research that could lead to interventions that would reduce vulnerability and strengthen the resilience we knew was there against HIV, and then also to mobilize heterosexual African, Caribbean, and Black men in Canada, and specifically in Ontario, and their communities to implement programs and policies and services that would address HIV. So returning to the issue of resilience, something we know about resilience is that it's not a static thing that you either have or you don't have, or you have it and that's it. It's something that develops over a lifetime, and its presence, its ability as a capacity in individuals, and I'd say in communities, changes in response to the environmental circumstances. And part of the critique about the way that resilience has been used in the past is that it really focused on individual psychology. And even though it was understood to be something that developed as part of grappling with, dealing with environments around an individual, the environments themselves weren't really given that much consideration. Instead, there was this focus on individuals and their psychology. So certainly issues around racism, classism, sexism, homophobia, transphobia, all these other things that compelled resilience were not really part of the discussion. Even though these are things that obviously were part of the situations of crisis, disruption, and adversity that require resilience in the first place. There's also some writing that really talks about how resilience has been a quite culture-bound notion, that that the way that we have come to understand resilience and talk about it was developed in a sort of middle-class, urban, white context that sort of had, identified these different variables that were supposed to represent resilience and didn't really cross that well into a lot of other experiences. So in terms of thinking about using resilience then with HIV prevention with Black men, on the one hand, we know that there's this work that says that resilience is important, that if you're thinking about strengths-based approaches, that this is really a key concept to integrate into work on HIV prevention. But then on the other hand, we have these issues with it being white and it's centered, with it really being psychologically focused, with it not attending to the environmental issues that we know were implicated in the HIV that we're trying to prevent. So people who were working on it from this perspective started to do work that would really focus on how resilience was defined for specific populations. So some of the US examples in terms of work that was done for heterosexual Black men are programs like Barbershop Talk with Brothers, another one called Straight Talk. There were others that were also developed for Black queer men. And really we're looking at how is resilience defined, experienced, understood for this population, and how does that then become something that we bring into an HIV prevention or sexual health interventions. And so really there was a need for similar work in Canada, because there are some aspects of that you can transfer, but part of what we're understanding about resilience is that it is so tied to the actual environment that people are in. It actually is an important difference that we are in Canada and that the men we are thinking about are in Canada, in Ontario, and the environment, the specific environment they're dealing with matters. So in terms of the methods, I'm reporting on the Toronto focus group research that was done in Toronto, but as part of a larger study, the We Speak study that rolled out for 5 years, had quantitative and qualitative components to it, and had 4 sites: Toronto, Ottawa, London, and Windsor. And in terms of the underpinning theoretical foundation of the project, it was very much oriented to the socio-environmental model of health and well-being, which calls attention to environmental factors that influence health and well-being for individuals and communities. And then also critical race theory, which calls attention to the consequences of anti-Black racism, including health consequences, and also intersectionality that would be represented in the lives of heterosexual Black men. So we recruited men via presentations to community stakeholders, services and service providers. There was a social media campaign as well. And to be eligible to participate in the study, you had to be at least 16 years old, self-identifying as African, Caribbean, or Black man, and heterosexual, and living in the Greater Toronto area. You could also communicate in either English or French because we did have a Francophone focus group. Now, part of our recruitment also included people that were living with HIV/AIDS because one of the underlying principles and values of the project was meaningful inclusion of people living with HIV and AIDS. And there was a participant honorarium of $30 for those that participated. So we had these 7 focus groups divided in the ways you see. So you see that some were concentrated around age groups, but then we also had this group for men who were living with HIV and a group for Francophone men. And when I wrote this up as a paper, there was a reviewer who had these questions like, why so many focus groups? Why such an age range? Why include HIV positive men? And I'm not clear that they were actually sort of suggesting that there were reasons not to do this, but maybe for just seeking a justification for why we would do this. And in some ways, are still puzzled by that because I think sexual health and HIV prevention in the Black communities, and especially amongst heterosexual Black men in the Black communities, certainly concerns men all across age groups, and certainly concerns men who are living with HIV. And so why this person would sort of question the inclusion is unclear to me, but it was certainly important to us to include these groups and to have this kind of range. So on the one hand, we're purposively sampling for men that are identifying as heterosexual and Black, but we're also accessing some diversity within that group because we want a diversity of perspectives on this. And we want to think about whether what we're doing needs to be modified or diversified based on the diversity in the population. The questions that were being discussed in the focus group, or some of the sort of main categories are here. So there were sort of opening questions that just got people to sort of brainstorm their thoughts on the connection between HIV and heterosexual Black men, questions about being straight and Black, about HIV vulnerability and resiliency, and just general resiliency. And in those questions, what you see is our focus on, or maybe what I need to say you should see, is that there is the focus on the social and environmental conditions when we're asking about what it means to be straight and a Black man in this moment, in this time, in this city, and what does it mean, or what helps Black men to be resilient. Of course, there are questions about HIV, but I also want to mention how an intersectionality perspective is also why we really want to understand that specific intersection of Blackness and maleness and heterosexuality, and how that shapes the realities that men are living with in terms of not just identities, but the social discourses and the social oppressions that affect them. For data analysis, it was a thematic analysis. So we had some codes that we started with based on our theoretical model, but emergent codes as we were working through it. And really an important part of the analysis for this work was work and discussion amongst the team, which themselves were members of the Black communities and could bring in different perspectives as members of the communities, as service providers, as researchers. This was a really important part of doing the work. So findings. In terms of an overview of the findings, there's sort of a set of findings that really are about how resilience is being defined by the men in these groups and the components of that. And then another set of findings grouped around how Black men in these groups saw the resilience as they understood it being something that could be mobilized in response to HIV/AIDS in the communities. So I'll start with theme 1. which is that resilience means being able to surmount difficulties. And this is sort of a quotation, it's taken from a quotation that is generated from a question about just what is resilience? What does it even mean to you? So in terms of some of the things that men were talking about, the types of difficulties that heterosexual Black men are encountering in this moment, in this time, and how the fact that you just know you're going to have to face certain kinds of problems with employment, problems with police, problems with stigma, all these sort of things, that these are part of the experiences of Black men, and that these were stressors and that these were just a constant context, but that also they understood these as being things that compelled resilience. Sorry, I'm in a very noisy place here. They compelled resilience because that was the only way to be able to navigate and keep going. And that determination and that capacity to keep going was their resilience. Something that they had earned in the moment because of the circumstances they are in right now, but also something that they understood as being intergenerationally part of being a heterosexual Black man. And one of the things that I do want to call attention to here is that vulnerability was not something that was being incorporated into any way of thinking about resilience. So there was some feeling that resilience implied that people were in conditions of vulnerability in some way, and that this was not something that these men saw as being part of the way they thought about resilience in relation to themselves. Another thing about the value of resilience, that although it was developed because of the difficult circumstances that these men had to navigate, that it was seen as valuable. So I'm just gonna go back for a second, because that quotation in the middle that talks about my Black skin, my Black brain gives me privilege, and I understand that, was really connected to this idea that the resilience that men had to develop was something that prepared them for life, that actually became an advantage in terms of their ability to deal with life. The flip side of that is talked about in this second quotation on this slide, is that it could also confer feelings of invulnerability and invincibility that could possibly make men feel like they could take risks and maybe not even perceive them as risks, that just the idea of being vulnerable to anything, including HIV, just didn't apply to them because that was not part of how they understood themselves as men. Another important thing that came out of the discussions about resilience was that, while there are sort of these received models about resilience being the ability to bounce back or to withstand, what really resonated, and you see how there's this, there's sort of this excitement in the discussion in this particular group, what really resonated was an idea that resilience is about feeling empowered, being empowered because you're equipped, being empowered because you've been tested and you have passed those tests, being empowered to take on whatever adverse situations you're in and that could come. And certainly part of what ended up sort of coming out through the discussions was that HIV, the threat of HIV in the Black communities was really understood to be yet another threat, yet another adverse circumstance, but that the men understood themselves and the men around them and the community around them as having withstood other kinds of threats and risks, and that they would be able to withstand this one as well. So that sort of transitions us to the discussion about the connection between resilience and HIV prevention. So since part of what men saw in their resilience was that it was defined by their capacity to work together or to work individually on behalf of their families and behalf of the communities, this was something that they were then able to be transferring over to the thoughts about how do you prevent HIV. So the kinds of roles that they saw for themselves was that they could be reaching out to other men, be part of a community of men that were working around issues of HIV prevention. So you see some of the things here. A man learns how to be a man from another man. We need situations where grown men can take initiatives, seeing themselves as able to also empower women, Black women in the community around HIV prevention. And then a contrast here too that, there was a specificity around it being things that were focused on heterosexual Black men, because there was some perception that they had been excluded from HIV efforts that were directed at men who were at sexual and gender minority men in the Black communities. And so a mix of feeling like they were being treated as outsiders in that effort. But I think I also have to say, also sometimes homophobia preventing them from feeling like they wanted to be included in those particular interventions or in those spaces, right? So, and you'll see, I'll talk about that in terms of the challenges for community engagement around this. Another thing that, really a lot of what they were saying is that they really just felt that people needed to be having discussions together, men needed to be having discussions together about these issues. And as you see, somebody from the university focus group talks about, we're having these important conversations in the context of this study. And it's just a shame that we don't do that more often, and we need to have these spaces. So here in this exchange, you see that, these young men, this from the adult group, are saying that they want to be part of those kinds of conversations, that they're actually equipping themselves to be part of those conversations. And, in this final quote, bit of the conversation here, the point is we need straight Black organizations that are for this, where the brothers can feel comfortable to be a part of the conversation. So a lot of things in that phrase, an idea about brothers being together and feeling comfortable to be part of the conversation, which kind of says something about feeling like that it was uncomfortable or that they were not part of the conversation. And then also this desire for something called straight Black organizations, or what they're defining as straight Black organizations. So in terms of the implications for defining resilience for Canadian heterosexual Black men, and I put in brackets Toronto because that's where the work was, it really seems that part of what we learned in this study is that the way that this group of men is defining resilience really rests on ideas of strength, determination, persistence, and de-emphasizes vulnerability, right? So understanding themselves as these determined, strong men who are, just the latest in a line of determined, strong people who have withstand so many other things, that is the way that they want to talk about resilience, and understand it as being connected to something multi-generational and collective in the community. And that they really recognized and asserted the importance of recognizing the specific intersectional experiences that they had as Black men in this context, their racialized and gendered consequences, which means that they face certain risks that other groups don't, but also meant that they had certain responsibilities that other groups don't. And in this study, that was mostly about their leadership, their commitments to family, and their commitments to community. So other things that we learned is that, in terms of thinking about HIV prevention with heterosexual Black men, that, we have to take into account the context of systemic racism, the social context, the economic context, and how those are implicated in HIV risk, and how this is also part of what makes them prepared to deal with HIV risk as another challenge that they face as a community. I've already talked about them preferring to see themselves as empowered and challenged rather than in need of resilience or vulnerable in some way that requires resilience. And then also that their ideas of what heterosexual Black men are, the archetypes, may in some ways be implicated in HIV risk when it's applied in ways that are about sort of hypermasculinity and, certain types of sexual behavior. But it's also something that can be mobilized to promote safer sexual practices, because part of that archetype is also responsibility to family community. I think another important piece here, maybe you're giving me time here, is that there needs to be Black leadership in the HIV response. And they were really talking about heterosexual men leading responses for heterosexual Black men, but just generally that we need Black leadership for resources, for services. And then there needs to be investment in existing community networks and connections.
Dr. Williams, can you wrap up, please?
I am wrapping up right now. So challenges for community engagement are that are HIV stigma and homophobia, the disengagement from existing HIV services, which I think is well known to us, and the perceived exclusion from that. And you know what? I can actually leave it there. Limitations, nothing that's going to surprise you. Self-selected group of men, focus group research means that there's group think sometimes and social desirability bias. And of course, we were focused on resilience. Okay, I'm happy to end there. Sorry if I went over.
Thank you very much.
I need to stop sharing, yeah?
Yeah, we have to move on to the next presenter because we went over time.
Sorry.
And it's okay, if there are any questions in the chat, we can always share them later on. So far there are comments, but no questions. So we will move to Natasha, who is going to talk to us about constrained choices and HIV risk of queer African refugees in the Canadian refugee determination process. Natasha is coming from the University of Toronto, Scarborough campus. Go ahead. I will disappear and show up again 8 minutes. That means you have 2 minutes and then 5 minutes for questions.
Fantastic. Thank you so much. I just want to make sure you can see my screen. Yes?
Yes, we can.
Fantastic. My name is Notisha Massaquoi, and I am an assistant professor with the Department of Health and Society at the University of Toronto Scarborough campus. I'm very pleased to be presenting today at CAHR. I'll be talking about queer African refugees and their HIV risk that occurs within the Canadian refugee determination process. It's very important for us to understand this population for 2 reasons. As we are moving towards the elimination of HIV and the goal of reaching the 90-90-90 targets, what is quite evident is how Black communities are being left behind in achieving that goal. We have to understand the diversity within the Black ACB communities in particular, to understand some subpopulations who are even at greater risk that we need to pay attention to. And the LGBT community is one of those subgroups within the Black population that we have to think about, and not just them as being queer, but queer refugees in the determination process are a very particular group that often gets ignored. The second thing that I think we have to think about today as well is, again, as we're trying to reach those 90-90-90 targets that have been set out for us, there's often a belief that the ACB population will not reach those targets because of the incoming number of immigrants and refugees who arrive here HIV positive. What I want to highlight today is that that is not necessarily the case. That is not what is not going to allow us to reach those targets. That many of those people experience HIV risk and HIV after arrival in Canada. Refugee claims based on SOGI persecution, sexual orientation and gender identity persecution, make up 12% of the refugee cases in Canada. And the largest proportion of those cases are queer African refugees, making up 27% of all SOGI cases. The research that I'm going to be presenting today was part of my doctoral dissertation. I was looking not specifically at HIV risk, but looking at the experiences that queer African refugees have negotiating their identities and their security upon claiming refugee status in Canada. And I was looking at the difficulties one would experience going through that process with those 2 identities in place, many identities, but the 2 in particular, being African and being queer. My study took place over 24 months, and during that period, I interviewed 40 queer African refugees in depth, and not only interviewed them, along with 13 key informants, but engaged in the process of queer phenomenology, where my own identity as a queer African immigrant was very much immersed in following the experiences that these 40 queer African refugees were having. So very intimate engagement on an often daily basis. I employed critical race theory as well in terms of my analysis, and in-depth interviews and surveys were conducted throughout the process. I also conducted bi-weekly support groups to support people going through the determination process at the request of the participants, understanding that my background was in social work and that I could provide a certain level of support. I also provided support with the refugee applications to prepare people for hearings, and often was an expert witness in the refugee hearings on behalf of the participants. The interviews and the documents that were collected throughout the process also supported the creation of the document package that refugees have to submit prior to their hearing. And so the interview was very crucial for the participants in this study because it became part of their application to prove their identities. Just in terms of demographics, so you get an understanding of who we're talking about. You can see the gender breakdown. 10% of this population identified as trans men and trans women, 50% identified as male, 40% identified as female. In terms of the port of entry, where they first arrived in Canada, Toronto was the most documented spot of arrival in terms of claiming refugee status. In the sample, we also saw the range of years in Canada from 1 week to 9 years of the participants. Their age range was between 18 years of age and 47. All participants spoke one of the 2 official languages of Canada, and they represented 11 African countries. All regions of Africa were represented with the exception of North Africa. In terms of the types of persecution that people experienced prior to migration, physical violence was at the highest rate. You can also see incarceration and torture. Sexual violence was quite high, and forced marriage was also a unique form of violence experienced by this particular population. In terms of chronic illnesses that were reported by the population, 35% of the participants identified as being HIV positive, and 40% self-identified depression as being a chronic illness that they were experiencing. Today, I'm going to be focusing on the percentage that identified as HIV positive and looking at, while the percent is high, it was not noted if HIV was contracted prior to arrival or post-arrival in Canada. It's important to note that this population does undergo a medical upon arrival as part of their refugee process. So they do know if they are HIV positive upon arrival versus those who became HIV positive after coming to Canada and claiming refugee status. One of the things that is important to highlight in the construction of the model that I am proposing that we need to look at in terms of understanding HIV risk for this population is that we clearly understand what life was like prior to arrival in Canada. We often begin our engagement with refugees at the point of entry. It's important to understand what led to flight and what led to one choosing Canada in particular to come for this particular group, and what the experience is at the point of claiming refugee status. It's important to understand that one does not leave their country with a refugee identity, but upon arrival in Canada, one must claim a refugee identity. There is a long process between making that refugee claim and your refugee claim being accepted. This is the period that one needs to understand very clearly so that you can see the HIV risk that is prevalent with this population. There are many things that need to happen for SOGI refugee claimants. One, they have to become conversant in the language of being a queer refugee, so much so that one has to convince a refugee board that they are someone who inhabits that identity. One has to become settled in Canada to show that they will be a productive citizen, and one must learn to navigate a new country and new experiences, all in a very short period of time so that one can have a successful refugee hearing. One of the things that is important to understand prior to arrival is something that I call heterosexual performance, and how that leaves one at risk for HIV, increased risk for HIV. Gay refugees, African refugees are both the easiest cases and the hardest at the same time in terms of proving that their life will be in danger if returned home, that they are indeed in need of protection in Canada. That's easy. Proving that they belong to an oppressed group, that they are in fact gay, is the difficult part. They have spent their entire lives carefully hiding their identity. So they come with no pictures, letters, evidence of living with partners, no friends, family, or lovers who are willing to testify or send statements on their behalf. They do not belong to gay groups or associations publicly. There is no evidence. They, of all my clients, have effectively erased this whole part of their lives from public view. The heterosexual performance that one needs to engage in order to survive is one of the HIV risks that one, increased HIV risks that one needs to be aware of. To become a successful refugee claimant based on sexual orientation or gender identity, one also has to be able to what I call perform this identity. I was advised by my lawyer to gay it up a little bit in the hearing, don't dress, don't wear what you usually dress. You're too butch, too masculine if you're a man. Like wear a pink shirt, wear something like what you would wear to go to a club, dancing, Do you use makeup? Maybe you can add a little bit mascara to your eyes. People engaged in the performance of what one might think would be queer enough for the refugee board to identify you as one who belongs to this population. Again, the performance increases one's risk for HIV. And we're also seeing the incidence of HIV rising in that population. So they're not necessarily coming HIV positive, but you get catapulted into a new culture, sort of a gay lifestyle. There's a lot of issues around proving that you're gay and people being sort of forced into, okay, I've got to make sure I'm at Pride. I've got to make sure I'm at these clubs. I've got to make sure I'm at the bathhouse. I've got to get pictures of all of these things. And then exposing people to HIV risk as well. What I am developing is what I call the Queer African Refugee Social Determinants of Health model. These are all the things that they are navigating and trying to overcome during this process of becoming successful refugee claimants. What these things do are constrain the choices that one is able to make in terms of their sexual health and their HIV prevention choices. And this is what increases HIV risk. And you can see them here. I'm going to highlight just a few for you today. In terms of access to information, being a social determinant of health that constrains one's choices and increases one's HIV risk. Okay, everybody knows that it's very hard to be out as gay, lesbian, transsexual, transgender in Africa, especially when it comes to talk about HIV. It's very hard because people used to say that, okay, the gay community is responsible for spreading HIV. So they're dying of HIV if it's killing them. We don't want to deal with them in terms of helping them. So when you come here, we are used to not taking care of our health or getting information about HIV or even talking about practicing safe sex. In terms of violence, I was raped by my landlord when I first came to Canada. It's very clear. Oftentimes with refugees, we focus on the violence prior to Canada. We don't think about the level of violence, risk, and vulnerability that this population has upon arrival in Canada. In terms of housing, I needed a place to stay, and this Canadian couple said I could stay with them. It's in a nice house for free. They were both HIV positive, and I knew the risk I was taking. I was an HIV educator at home, but when you're trying to survive, you take risks. Imagine I came to this country to get HIV. So oftentimes one, because of socioeconomic status, is exchanging sexual favors for housing and other things that one might need to survive during this process of refugee determination. Isolation as a social determinant of health. So you're going to have sex with me, and if I start putting up barriers or saying you need to use a condom, you're going to say, okay, fine, forget it. What? Because I'm not exactly what you're looking for to begin with, because of who I am ethnically or racially. Therefore, okay, well, I'm getting lonely. Okay, so maybe I'm not going to talk about condoms, that sort of thing. And finally, anti-Black racism. And also when it comes to just accessing services and settling into the city, I mean, racism against Black people is very evident everywhere. Now to add to it being refugee, being vulnerable that way, don't have the empowerment of money and work and education, all these things make it much worse for people to get involved and put them in poverty situations and health risks and all of that. It's important for us to understand this population and their vulnerability, as well as the increased risk of HIV due to constrained choices. Queer Africans are at higher risk for HIV infection post-migration due to several compounding factors, including the refugee determination process and requirements, complex settlement challenges, pre- and post-migration trauma, limited employment opportunities, poverty, challenges accessing services, stigma, discrimination, and anti-Black racism. The refugee process inevitably increases level of stress, and this elevation in turn increases risky behavior and reduced health prevention and health-seeking tendencies. Equitable responses to HIV for Black communities must also consider those in various stages of the refugee determination process, and new models which account for diverse Black experiences navigating HIV within a Canadian context must be highlighted and recognized. I'm going to stop here for time. Thank you all for your attention. And I want to especially thank my participants who spent an enormous amount of time providing me with in-depth understanding of their lives in Canada.
Thank you, Notisha, for a great presentation. Unfortunately, we don't have time for questions. There are a few comments giving you thumbs up. I should let you know, but we have to move on to Josephine, who is going to talk to us about responding to community needs during COVID, facilitated barriers and effectiveness in using the CHAMPS online intervention to reduce HIV stigma and promote empowerment. Josephine, are you here?
Yes,
Yeah,
I am.
thank you. I will show up again when you have 2 minutes to your presentation time, and then there will be questions.
Okay, all right. Isaac, you're making me nervous.
Yeah. That's my job. I was told what to do. Thank you. Yeah.
Great. Thank you very much. Can you see my slides move?
Your slides are perfectly fine.
Okay, great. Thank you very much. I appreciate the opportunity to be here with everyone and my team members on the slides here, Dr. Ellen Lee, Solomon, Loam, and Kishore, as well as our entire team. And what I'm focusing on is CHAMPS in action. I would also like to take this time to acknowledge that I am talking to you from Toronto, which is also known as the place in the water where the trees are standing, the place where the fish weirs are, as a reminder that even though concrete have poured over Toronto, it is Indigenous land. And I am reminding myself to be committed to act in solidarity to dismantle the structural violence and the systemic oppressions that are still experienced by Indigenous people, Black peoples, and racialized peoples. So CHAMPS in Action is a 5-year community-based health promotion program that had been funded by the Public Health Agency of Canada. And you can see here that our partners are 5 a service organization that is actually quite active and well-known in Toronto. We declare that there is no conflict of interest. So the CHAMPS in Action is actually evidence-informed intervention that's based on a study that we had carried out before. And the purpose is to reduce stigma, to enhance effectiveness in HIV response. We work with the African, Caribbean, Asian, and Latinx communities in Toronto, including people who are living with HIV from the LGBTQ plus communities, as well as newcomers, refugees. And so we focus on building capacity amongst community members so that it will not just be a program that once the funding is over, then it's gone. We designed it such a way that we will build a community of practice to facilitate sustainable actions and programming. So as all of us would recall, then in March of 2020, so Champs in Action is from 2017 to 2022. So right in the middle of it, we had a pandemic. So what does that mean? So we have all experience. I don't really have to say much. One of our cohort with the Center for Spanish-Speaking People actually had delivered 2 days out of the 4 full days training. And we didn't know what to do because people are not allowed to get together. And so then we did some discussion across the alliance, and we decided that we had to do something to respond to the needs of the communities. And we want to assess what is happening. And so we sent out a survey to more than 200 service users, community members, and of course, we only had about 68 of them returning. And more than 80% of the people who replied to the survey actually said that they experienced medium to high level of stress. And the area of stress was the fear of getting infected, especially amongst members who are living with HIV. Many of them are also worried about the work conditions, as many of us are aware that people who are racialized and immigrants and refugees often are in the kind of work that is essential but not actually acknowledged as places that would be giving the safe protective gears. And what they find was supporting them was actually going online, reading, exercising. That's how they keep themselves well. And the kind of resources they really need is actually mental health check-in on top of all the material and financial stuff that they need. And they also talk about that, yes, they're able to actually connect by Zoom because we were trying to assess that how do we actually deliver program and services, not only Champs in Action, but about all the other supportive programming that is happening. And they identified during the day as preferred time, but in the afternoon, because in the daytime, they had to, many of them actually had to deal with the kind of demands that is also at home. And this is actually one thing that we found, and it was in some way, despite all the stress, is to know that Champs in Action actually helped. So one of the participants actually in the evaluation talked about how this person was able to apply what they have learned in Champs to actually support themselves. And it also showed that our rapid response to reach out to the community was helpful because even though we couldn't do the in-person intervention, the workers and staff from the ASO were able to actually connect them and develop all kinds of information to remind them what they have learned in CHAM and to apply those. And this is someone who actually shared that not only did she use the information and the skills, were able to actually do it with friends, and many of them are also refugees. So then when we think about what we need to do, because the pandemic did not disappear, we realized that we have to prepare and actually go online just like everybody else. But our program going online is a lot more complicated than other programs like counseling, because it is a program with many activities. And so what we did was, while we were preparing, we converted. My colleague Alan and I did not have any vacation at all for the winter holidays, and we actually just work on almost nonstop, turning everything that was from a 4-day in-person sessions into 6 online modules, and accompanied by a weekly 2-hour online group session. And so these are the people who had actually go online in 2021. The entire project had just wrapped up this past month in March. And you see that we enroll 114 people, 69 completed, but this number actually is related to, we're not able to do the 3 months follow-up. A larger number of people actually had completed entire training, but is doing their post-survey, that they didn't do them. And when they don't do their post-survey, we're not able to actually use the data. And you see that our participants are surface user as well as surface providers. And you see that we also had people living with HIV and gender diversity, as well as sexual diversity amongst our participants. And this is just a quick overview of the model that we use is to, we actually integrated a psychological model that actually will increase people's psychological flexibility so they're better able to cope with stress. But on top of that, based on our experience in the past 10 years, we realized that no, we cannot just do psychological individual work without actually taking in all the structural factors. And therefore, we also integrated empowerment education that is based on the influence of Paulo Freire and do this and integrate it into this. And so this is a picture of part of the activities. This is called the Sculpture of Suffering. And when we do it in person, we actually all take our chairs to put onto a chair. And it actually took quite a bit of work and the support of a computer technician to help us to do that. So we invited the participant to think about all these chairs at the strategies that they use to cope with something that make them feel bad about who they are, is stigmatizing, and then place them in relation to the chair. And you see that after they place there, many of them actually had a lot of reflection. And we were actually quite happy and surprised that when we don't do it in person, it still works. So these are some of the things that they talk about, that even though they try to use all these strategies, the negative emotion did not really disappear. The person still feel anxious, and the chair of suffering is still in the middle. So the whole point is actually about sometimes we use so many strategies to try to avoid facing or dealing with those internal struggles that we actually had no time to fight the real injustices out there. And this is a diagram based on our pre and post survey. And we can see here that we had medium and significant in the area about mindfulness. Mindfulness becomes something that people really talk about, I think partly because of social isolation. They also experience resilience, even though it's a small effect collectively, but for some of the participants, their difference was over 150%. Empowerment, absolutely, and confidence to act, that is to speak out against stigma, to speak out against injustices. The well-being, we suspect that the significance collectively did not show up because they were still highly stressed because of the pandemic. And the HIV stigma part, we are finding that stigma scales are actually a little bit too obvious. And so people fill out the survey in ways that they didn't have a whole lot of room to become less stigmatized afterwards. And then action was actually also very powerful. And these are some of the evaluation. We just completed our evaluation focus group last month. And the service providers who are in the program said that it really helped them to listen to their clients. They actually see things differently. They build collective resilience to address structural violence. And others said that they joined the program and joined the train the trainer capacity program because they feel it helped them so much they want to help other people. So what is the next step? We are still doing detailed data analysis to gain insights about online stigma reduction and empowerment. We are fortunate in a sense that we had in-person for 2 years, and then we had online for 1 year, so we can compare the data. We want to continue with the community of practice to build capacity. And we want to actually look at the challenges of digital divide, which was a big thing about doing online as well as completing the survey. And we also actually had an A study that will be rolling out this summer in Alberta and Ontario. And that's all I have.
Thank you. Great. We actually have time for one quick question. I don't see any question in the discussion forum if someone has something. So if there's no question, we're actually running out of time. Josephine, I think, thank you so much for such a great presentation. We will move to our next presenter, who is Wally Ajiboye, in place of Kamenda. And Wally is going to talk to us about I Am Ready program assessment results, African, Caribbean, and Black participants accessing HIV self-testing across Canada. Wally, go for it. I will disappear and show up when you have 2 minutes to the end.
Yeah, so I hope you can see my screen.
Yes, it's looking good.
Okay, yeah. Yeah, so good afternoon, everyone. My name is Wale Ajiboye, and I'm presenting on behalf of Caminda. I'll be presenting data from the first 9 months of the I'm Ready HIV self-testing program, in particular around the participation of individuals from the ACB population across Canada. By way of background on the I'm Ready program, the main goal actually is to reach the estimated 8,000 plus individuals living with HIV who remain undiagnosed across Canada, and also to link them to care. And to be able to do so, Reach Nexus at St. Michael's Hospital, together with all the partners, implemented the I'm Ready program in June 2021. The program essentially utilizes a mobile app that provides access to free HIV test kits to participants by mail or to be picked up at one of over 80 community-based organization partner sites across Canada. Now, the I'm Ready program also has a comprehensive website that provides pathways to care and prevention services for each province, as well as a virtual telehealth platform that is staffed by peer navigator for support before, during, and after self-testing. Now let's talk about ACB communities and HIV. We all know that African, Caribbean, Black communities in Canada continue to be disproportionately affected by HIV in Canada. And we also know that experiences of multiple dimensions of stigma and discrimination, which is now compounded by the COVID-19 pandemic, have actually exacerbated this impact by specifically reducing access to testing facilities and interrupting linkage to care. So in the I'm Ready program, participants actually provided demographic and health information through anonymous pre- and post-test survey via the mobile app. And next you will be hearing, I'll be talking about the results of what we were able to find out in the last 9 months. So this is ACB participation by, province. ACB participation have come from all regions of province, as you can see, regions of Canada, as you can see in the slide here. Of note, actually, is the fact that 6 out of 10 participants are from cities, towns, and communities with less than 100,000 population. So, I mean, the participants have not just come from large communities, but also from communities with population below 100,000. Now, when you look at, the overall participants, the program has also captured all the major key populations. 57 identified with at least one key or priority population. The ACB population represents about 11% of the overall program population to date, with GBMSM participation being the highest of key populations, and that is at 39%, while participation from indigenous and people who use drugs remain quite low at 4% and 3% respectively, as we can see in the chart. Quarterly enrollment by priority populations. Participant uptake, as we can see here, by ACB individuals remain consistent throughout the entire 3 quarters in the last 9 months. And we can see that in yellow. That consistent participant trend is also similar in other key populations, as shown in other color. Now, key populations by region. We can see here that the I'm Ready program is reaching people from key populations, including ACB peoples across all regions in Canada. Although there are slight variations in ACB uptake across regions, as seen in yellow again, ranging from 21% in Ontario, 20% in Quebec, down to 9% in British Columbia. And of course, for the Atlantic Canada and the Prairie provinces, we have rates in between 21 and 9%. Now, I'll be focusing, the next few slides, I'll be focusing on the data from the ACB community. Now, this is the data for the socio-economic characteristics, focusing on the ACB community specifically. Now, majority had post-secondary education, majority that participated in the program. Nearly half of the ACB participants indicated they were employed full-time, with others indicating part-time or self-employment. 20% were students, and 11% indicated they were unemployed. In terms of income, it was divided 50-50, using the reference range of $30,000 per annum. 50% indicated income below that, and 50% indicated income above $30,000. Now, the social demographic characteristics is shown here. Over half of all ACB participants were below 30 years of age, and this indicates that the program, the I'm Ready program, is really resonating with younger ACB folks. Now, 50% of ACB participants are identified as a man, 45% as a woman, and 5% indicated other gender identities. 24% of ACB participants were Francophone, and the majority, that's 56%, indicated their sexual orientation was heterosexual, with 27 as gay, bisexual, and 17 others. So let's look at the immigration status. The majority of ACB participants, 77% to be specific, were either born in Canada or had become Canadian citizens at the time of participation in the program. However, there is ACB representation from students, visitors, folks on temporary work permits, refugees, and those that also indicated that they are non-status. Now, the overall health of participants, this is in comparison to other participants. Now, 3 out of 4 ACB participants have good, very good, or excellent overall health, shown here in red, in comparison to other key populations. And we can also see that 1 out of 4 have indicated significant depression, and 4 out of 10 have significant alcohol use. Now, sexual health behavior among the ACB participants. This is striking, actually, because of note, 22% of ACB participants have indicated never having been tested for HIV. PrEP uptake is also very low among ACB participants in the program, with only 6 individuals currently taking PrEP, and that's like 2%. And 3%, of participants said they had previously taken it, but they had stopped. In an earlier survey, 7 to 10 respondents indicated that COVID-19 negatively impacted their access to general health care and HIV and sexual health services. Now, bringing all this together, I mean, what is actually the conclusion? Participation in the I'm Ready by ACB individuals has been steady, although below expectation. Opportunities actually remain to reach subsets underrepresented in this initial sample. And what we're doing currently is to embark on population-specific engagement efforts, which are currently being led by ACB community leaders across Canada. Thank you for listening.
Thank you very much, Wale. You finished right on time. So you have a couple of minutes for questions. And there's a question from a participant. What do you attribute to the low numbers among ACB and indigenous communities? What do you attribute to the low numbers among ACB and indigenous communities?
Yeah, I mean, relatively, I think that the numbers that we have is low because in the last 9 months, the strategy has actually been to, reach out to participants through community organization and social platform media. But now we are trying to target, specific, groups that we know that, should be represented, like students, people from Francophone, and also PrEP eligible individuals. And, we already have planned in terms of social engagement, strategies to be able to do this. Yeah, so I think it may, probably be connected with reluctance, in terms of the challenges that, members of our community have traditionally faced in terms of confidentiality, which is something that is, positive with this program, because you can be assured of confidentiality, but yet people are still reluctant, as a result of that. So I think that is what could be responsible. But all those will be addressed in the new strategy to enhance uptake.
Right. Very, very quickly. Another question is, who are your ACP partners involved in the I'm Ready project? Yeah.
I'm sorry about that. Let me share my screen again. I think I missed that slide.
Very quickly.
Yes.
Okay.
Yeah. Okay, so these are our partners and funders. For funders, we have CAHR, Canadian Foundation for AIDS Research, Public Health Agency of Canada, and our partners include CBRC, Women's Health in Women's Hand, and SHABAC, and the host, of course, is Rich Nexus, MAP Center for Biohazard Solution at St. Michael's Hospital. I'm sorry, this was part of the slide, but I was trying to be conscious of time and I missed that out. Thank you for that question. Yeah,
that's good. Okay, thank you very much for a great presentation. We will move to the next presenter, Dr. Bluma Brenner from McGill, and he's going to talk to us about the dual selections that are favorable, Deroverine, and wow, I have to stop. You have to read it for us. There are top names here. Yeah. Can you tell us what you're going to talk about, Bluma?
Okay, it says I can't share screen because the other.
Yes, I'm trying to stop sharing now. Okay.
Okay, now you can share your screen.
So do you see my screen?
Yep, it looks good.
Okay, so I'm a basic researcher in a session talking about African, Caribbean, and Black populations. And hopefully I'm going to discuss recent advances with the potential of using drugs like Doravirine for the epidemic control. So HIV is very complex and it's spread throughout the world. It's not only attacking the immune system of the individual, but the immune system of society. And the epidemic is spreading in the Western world among men having sex with men and heterosexual populations, such as Blacks, and but throughout the world, it's endemic to Africa. And in Quebec, half of our epidemic can be ascribed to new infections arising in individuals who have arrived from countries throughout the world, from Francophone countries in Africa, from France, and we have a huge Haitian community. So we have to be able to manage the HIV epidemic, not simply among men having sex with men, but as well for heterosexual populations. There has been a dramatic HIV is a deadly disease at the very beginning, and 70 million people have been infected, 35 million people have died. But antiretroviral therapy offers the opportunity to treat HIV infection in the individual, but not simply treat the individual, but once an individual is treated and their viral load goes to undetectable, there's no transmission. And I worked for many years with Mark Weinberg, who advocated for HIV drugs to be available in Africa. And we can see that there's been a 35% reduction in the epidemic in Africa over the last decade. And 90-90-90 goals are being reached in Africa, despite having relatively weak healthcare systems. So constantly drug companies, there's over 30 drugs available, are trying to make cost-effective therapies to be used throughout the world. And with the advances in therapy, there has been a shift towards the use of integrase inhibitors, and in the Western world, as well as in Africa. But newer drugs are being designed, streamlined therapies, because individuals will have to be treated throughout the course of their life. People develop resistance, and we need long-acting drugs. And doravirine, islatravir, was a suggested drug that can be used as to be used as injectables and for long-term management of HIV. And also, doravirine has been proposed and recommended for, in the European guidelines because of the low cost and the ability to be used in lower income countries. Now, so unfortunately, in the injectables, there has been a problem with islatravir, and it is currently not being used, but I don't think this will affect my discussion. So if we look in Quebec, we can see that the men having sex with men epidemic has dramatically declined in the 90-90 era because of the availability of drugs preventing not only the infection in the individual, but also preventing onward transmission. And yet there are clustering of outbreaks, and using clustering of outbreaks, I can say, and having done a study with Réjean Thomas at Clinique Actuelle, approximately 25% of new infections are arriving in individuals who are born outside Canada, among Latino and Black populations, and they're acquiring the epidemic in the province. So we have to make sure that therapies are available for men having sex with men in high-risk populations. But there's also a heterosexual epidemic from individuals who have arrived, non-B subtypes in green show. These are individuals arriving from Africa. Subtype B infections represent epidemics that are arising from individuals from countries in the Caribbean and South America. So with the rollout and scale up of drugs in Africa, less expensive drugs were used, and there has been individuals who've acquired resistance to non-nucleoside reverse transcriptase drugs, one of the anchor drugs used in treatment. Since this resistance is there, then we don't want to have any of the benefit that has been arisen from using antiretroviral drugs to impair the ability for these drugs to be operational. Although integrase inhibitors have a very high barrier to resistance, there is still an argument for the use of non-nucleoside reverse transcriptase inhibitors for particular populations and their potential benefit. Integrase inhibitors have resulted in weight gain, and recently in a recent study by Sachs, the women have gained over 10 kilograms in 96 weeks. So therefore, there's a potential that integrase inhibitors might not be the ideal therapy for certain groups of women. The European guidelines include doravirine as a potential drug for the treatment of HIV, and long-acting regimens are including non-nucleoside inhibitors such as doravirine and rilpivirine. So one of the anchor drugs in antiviral regimens was the original Atripla, generic type of Atripla used in Africa. And that was really a benefit, but individuals developed resistance to efavirenz. So doravirine has been designed as a drug that is active against these viruses that harbor resistance to efavirenz. And so it has an ability to interact with the 103N and the 181 and the 190 mutations that can confer resistance to non-nucleoside reverse transcriptase inhibitors. So with a grant funded by Merck, we monitored the type of resistance that arises with doravirine and to see how beneficial doravirine is with another drug, rilpivirine, which also is reactive against viruses that have drug resistance to efavirenz through mutations such as 103N. And so we did an experiment in cell culture, and we do low levels of culture, and we monitor mutations, and we're able to describe the mutations that can confer resistance to doravirine as opposed to efavirenz and rilpivirine. And we see that doravirine has a specific mutational pattern, and if we grow it in culture, we can describe the acquisition of mutations and what will arise in cell culture. In the real world, its resistance mutations take a long time to develop, and the mutations, so we see that V108I will be the mutation that will arise if individuals ever develop resistance to doravirine. And E138K is the mutation that will arise if individuals fail therapy with rilpivirine. And cabotegravir rilpivirine has been used as an injectable drug, and in the clinic, we are seeing that E138K can arise in individuals who harbor a subtype of virus that is spreading in former Soviet bloc countries with a subtype A virus. So what we see in cell culture tends to match what we can see in vivo. What we can see, that is, if we combine doravirine with islatravir, we don't see any mutations, and islatravir is a very strong drug. And we see that the combinations will reduce the appearance of E138K as well with rilpivirine. So we see that there's a potential of having long-acting regimens with doravirine and islatravir, as well as a beneficial effect if it's ever given in oral drug doses. When we look,
Bluma, could you try and wrap up?
Yes, if we look at doravirine, we can see that doravirine resistance, the viruses remain sensitive to rilpivirine. And so, oh, sorry, I'm going the wrong direction. Okay. So we see that doravirine is very, very potent drug. The resistance that occurs with doravirine, the viruses remain sensitive to the other non-nucleoside reverse transcriptase. So doravirine has a novel resistance pathway and it has a unique resistance profile, and it has a potential for use for those individuals who cannot tolerate integrase inhibitors, and it might be a particularly good drug that's cost effective to be used in third world settings, and as well for women who might have adverse effects with integrase inhibitors. And it is being explored as a potent long-acting two-drug strategies, although it's on temporary hold because of toxicity. Thank you.
Thank you very much. Unfortunately, we are running dangerously out of time for Lyle, and so we will have to move to the last presentation in this session, and that will be Lyle McKinnon, Dr. Lyle McKinnon, and the title of the talk is Correlates of Genital Immune Cell Frequencies in South African Women and the Risk of HIV Infection, a prospective cohort analysis. All right, we can see your presentation quite clearly. I will disappear and show up again when you are on about 2 minutes left for the presentation session. All right, thank you.
Thanks very much, Isaac, and good afternoon, everyone. So my talk is going to be about HIV susceptibility today, and we know that this varies greatly within populations. And I think a lot of talks in this session and at this meeting have highlighted the various sort of levels of variables that influence HIV susceptibility. And these are all really critically important to take into account when we think about HIV prevention. My lab focuses mostly on biological factors and a little bit on sexual networks as well. And I'll be really talking about biological factors today that influence susceptibility in women. And so when we talk about sexual transmission of HIV, we know that the virus has to get across the mucosal barrier. It has to find a suitable number of target cells to infect. And eventually it has to get out of the mucosa and into the sort of lymphocyte-rich parts of the body, such as the blood and the lymph nodes. And there's a lot of unknowns, I think, about how this actually happens in humans. And it's really important to study this in humans so we can also at the same time capture the epidemiology of transmission in our studies. And today I'll be talking a lot about target cells. So we and others have shown that genital inflammation is an important risk factor for HIV. So if you define this by elevated cytokines in genital secretions, we found about a threefold increased risk of HIV in women who had inflammation. And we think there's a plausible biological pathway by which this happens. So if you have increases in cytokines, that can also be linked to increases in immune cells, and some of those immune cells are targets for HIV infection. And also cytokines can break down the mucosal barrier, which can in turn lead to more immune cell recruitment. And we think that aspects of this phenotype are what are mechanisms that increase HIV acquisition risk if a person becomes exposed to HIV during sex. And so our studies have really focused on cytokines and HIV outcome, but we haven't really had a chance to look at these other variables related to HIV in a prospective cohort study of humans. And that's what I'm going to talk about today. So basically CD4 positive T cells in the female genital tract may be critical to establish HIV infection, but we don't have any empirical data. And we know from other infections that there's cells that go to the tissue and actually live in that tissue long term. And these cells might be really important immunologically for preventing infections. But in the case of HIV might take advantage of this fact that we send cells out to our tissues to protect us from infection. Because of course, HIV can infect immune cells. So the study I'm going to talk about today is the Caprice 008 study. And this was a randomized trial that compared delivering tenofovir 1% gel as pre-exposure prophylaxis, either in a clinical trial versus family planning setting, and this was published a few years ago. We collected genital specimens every 6 months for 3 years, and we've carried out a number of studies of these specimens. One of these was just recently published in CID earlier this year, looking at the link between T cell activation and DATP, which we think might have impaired the ability of the gel to protect women. But what I'll talk about today is another analysis. So it was a prospective analysis of a number of women in the cohort, some of whom acquired HIV during follow-up. And this is just some of the baseline characteristics. So we studied about 181 women, and most women were studied about 5 or 6 total visits, again, twice per year. Most of the women were in their 20s. A large proportion used injectable hormonal contraceptives, which are common in this region. Median of 4 sex acts in the last month. Condom use, not that common, but a lot of the women would only be having sex with their regular partners or husbands or boyfriends. Bacterial STIs were fairly common, and about 1 in 5, and the specific STIs are listed there. HSV2 is very high in this region, so about 90% were HSV2 seropositive. About half had HPV at baseline, and about just over a quarter of women had either BV or intermediate flora by Nugent scoring. And so 96 or about half of the women had inflammation defined by 5 or more cytokines in the upper quartile at least one visit. And having inflammation, as expected, was associated with higher chlamydia prevalence, higher Nugent scores, and a greater number of partners reported to be living with HIV, so potential exposure to HIV infected partners. We carried out flow cytometry on these samples, and there's a little cartoon in the corner here showing how we collect samples from the female genital tract by cytobrushes. So this is similar to what would happen during a pap smear, where a cytobrush is inserted into the endocervix, and we can collect cells from that brush. And then we can profile those cells. So we can look at T cells, we can look at cells that are other immune cells that are not T cells, such as natural killer cells. And then on T cells, we can profile whether or not the cells express CD4 or CD8, and then a number of immune factors we think that are linked to HIV susceptibility, such as the HIV co-receptor, activation markers, and recent proliferation markers. And so if you look at women who never had genital inflammation, women who had it at some visits, so stratified by whether they had it at that visit, and then women who always had genital inflammation, you can see that there's an increase in endocervical lymphocytes. There's also an increase in CD4 positive T cells, particularly in the women who always had genital inflammation. And I'll break down how this worked out statistically on subsequent slides. But just note that this is a log scale. So even though this increase might not look like it's very much, it actually is, reasonably increased number of cells if you have genital inflammation. If you look at individual cytokines, and we ran a large panel of cytokines, you can see a lot of pro-inflammatory cytokines and chemokines. The boxes and circles here colored in dark are the ones that are significant after multiple test correction. And you can see that if these little box and whisker plots are above 0, that means more cells. So a lot of cytokines are associated with increases in cells. And this was true if you look at different subsets of immune cells. Pretty much most immune cells were associated with inflammation. And so I think this sort of backs up our previous data that we've published on this topic, that immune cells in the endocervix are linked to increases in cytokines and genital secretions. We also looked at barrier proteins, and we looked at these matrix matrix MMPs, which we know are biomarkers of the barrier. And you can see that by p-value and also by the log 10 increased concentration, a lot of these MMPs are associated with inflammation. So if you have more cytokines, then you have more of these MMPs, suggesting again that this link between cytokines and the mucosal barrier is there. And particularly, I want to draw your attention to MMP8 and MMP9. These are really strong neutrophil proteins biomarkers, and this is where the most significant increases were seen. So if we did a multivariable model and incorporated a lot of the variables we think might be important for predicting either inflammation or immune cells. And you can see here that the strongest predictor of having cells at the endocervix is inflammation in terms of elevated cytokines. So about a 0.25 log increase in your immune cells if you have inflammation. And this is in a linear mixed model that accounts for repeated measures. Also of note, STIs were associated with increased cells. And so this model controls for whether women had STIs. And it was also interesting to note that BV Nugent score was actually had an inverse trend towards immune cell concentrations, which I think would be surprising to a lot of people. And then the last bit of data I'm going to show, which is the sort of unexpected part, is that endocervical T cells for the most part, did not predict HIV outcomes like we thought they would. So even though the number of T cells is associated with inflammation and inflammation is associated with HIV, the number of T cells, either in a model that's sort of minimally adjusted for study arm and time, or a fully adjusted model, the only really association was with this one subset of CD8 positive T cells expressing HLA-DR, and these were actually protective. So a hazard ratio below 1 indicates a reduced risk of HIV infection. And so according to our sort of conceptual model, we predicted that a number of T cells, particularly CD4 positive T cells, would be associated with increased HIV risk. So just to conclude, we found strong associations in the study, as we have in previous studies and as other authors have found, between inflammatory cytokines, barrier proteins, and the number of genital immune cells. And again, that sort of fits into that model that I presented on the first couple of slides. However, the number of genital tract C4 cells was not associated with HIV outcome in our study, and I think these results obviously need to be validated in additional studies. One, if they do turn out to be true, one explanation could be that it's barrier breach that's more critical for HIV acquisition. And we do know that HIV is not transmitted in most exposures. So if you go back to our cartoon here, it could be that the virus normally doesn't get across this mucosal barrier, so it doesn't really matter how many T cells you have down here. And whenever it does get across the barrier, there are sufficient T cells for transmission. So it's difficult to test that, but that's one possibility. And another possibility is the type of sample we're taking might not be true tissue cells, for example, that you'd find in a biopsy. Biopsies are much more are complicated to take, and in South Africa, we actually can't take endocervical biopsies or ectocervical biopsies. But we have done a study in Canada where we have some information that suggests that the cells you get in a biopsy might not be the same cells you get in a cytobrush. And I guess the final conclusion is I think the timing and location of HIV establishment is really difficult to define in humans, but I think this is really important because this is where prevention needs to mediate its protective mechanisms. So it's something that still needs to be further studied. I'd just like to thank a large number of people from my lab and a lot of collaborations, particularly the study was done in South Africa. And a lot of the analysis was led by Lenine Lieberberg, who's a scientist at Caprice. A lot of support from the stats department with Naslantha and Farzana. And then Joanne Passmore was the PI on the NIH grant that funded the work, and I'm happy to answer any questions.
Thank you, Lyle, for a great presentation. You did well, and we have, our time is up, but given that we're already trailing, we have time for a couple of questions. And there are a couple of questions already, so I'll just read them. The first question says, did you see an association between MMPs and HIV transmission?
Yeah, that's a good question. So we focused this analysis on the T cell aspect, but I think that is something that while I was making this talk, I realized that we need to go back and do that. So I think there's some additional modeling that we need to do to understand these data. I don't think it's going to change the association between T cells and HIV, but that's something that I thought of actually just yesterday.
The second question says, do you think that the finding that more target cells are protective and not a risk factor may be related to HIV-specific cellular immunity?
Yeah, that's a great question, and that's something that definitely we thought about when we got these results. I think it's important to note, though, that it's not really target cells that are associated with protection. It's the although there are some trends there, but it's the CD8 positive T cells, and there's definitely a lot of thinking over the last few years that for a few decades even, that CD8 T cells at the site of exposure might be able to be protective. And so I would expect that maybe some of those cells might be HIV specific. So that's another great possibility to look into.
Right, we have one more question in the chat. Has there been any research to examine the influence of stress on vaginal and genital mucosal immunity and connect this to HIV research to expand beyond biological factors to include structural factors that cause stress and compromise genital mucosal cells?
Yeah, I think that's a great suggestion and thought. I think that's also a good example of the different layers of HIV susceptibility interacting with one another. I know that stress also is biological, though. So I know some investigators are looking at measuring cortisol, which is a marker of stress, and trying to link that to genital inflammation or systemic inflammation phenotypes. So I think there are some studies out there, either published or unpublished, that have focused on that. So I think that's a great thing to look into. There's some complications in terms of how to measure stress, I think, and time of the day you have to measure cortisol, if you do it biologically or exactly how you define it. But I think that's something that the more studies could look into.
I promise one final question.
Okay.
Francophone ACB have the chance to participate in this study?
Yeah, I think with better prevention, it's getting and that's a really good thing. It's getting harder to do these studies because you need obviously some people to get HIV to be able to have that longitudinal linkage with risk. If you look at people who are already HIV infected, then you don't know exactly what caused what, right? So at the time this study was done in South Africa, the HIV incidence was still quite high, and it was possible to get enough HIV endpoints to do this analysis. But even in KwaZulu-Natal, with prevention efforts, the number of new infections has come down. There's definitely, there's not that studies can't be done. I'm just talking very specifically about studies with HIV outcomes. But there's other studies that can be done for sure, in any population that tries to link these different biological factors together.
All right. Thank you very much. And thank you all the participants. I think that this was a great session, and this is the end of the session. Thank you. Bye.
Thanks for sharing. Thanks, everyone.
Yeah, bye.